Facial development follows a precise timeline, and understanding this sequence helps predict which structures are affected together. Week 4 marks the appearance of facial prominences, small bumps that will become recognizable features. During weeks 5 and 6, the frontonasal prominence meets and fuses with paired maxillary prominences. When this fusion fails, we see cleft lip. The critical window closes by week 7 when lip fusion completes. Palatal development occurs later and separately. Between weeks 8 and 12, the palatal shelves elevate from their vertical position alongside the tongue, rotate to horizontal, and fuse in the midline. This explains why isolated cleft palate occurs without cleft lip. The disruption happened after lip fusion was complete. Timing of the embryologic insult determines the defect pattern. Early disruption, around week 6, affects both lip and palate, resulting in complete unilateral or bilateral clefts. Later disruption, after week 8, causes isolated cleft palate. This temporal relationship helps with counseling. Complete clefts suggest earlier teratogenic exposure or genetic disruption, while isolated palatal clefts might result from later mechanical factors like oligohydramnios restricting jaw movement. Understanding this timeline also explains associated findings. Early disruptions often affect other midline structures, warranting careful evaluation of brain, heart, and genitourinary development. Classification of cleft lip guides both surgical planning and initial NICU management. The distinction between unilateral and bilateral clefts affects feeding approach and surgical complexity. Unilateral clefts occur more commonly on the left side, a consistent finding across populations that remains unexplained embryologically. Complete versus incomplete classification hinges on whether the defect extends through the nasal floor. Complete clefts breach the entire lip height, disrupting the nasal sill and often distorting nasal anatomy. These babies struggle more with feeding due to inability to generate negative pressure. Incomplete clefts maintain an intact nasal floor with a tissue bridge, however thin, connecting the lip segments. This preserved anatomy often allows better feeding success with standard bottles. Microform clefts present as subtle notching or scarring of the lip vermilion without obvious separation. Though cosmetically minor, they signal disrupted facial development and warrant evaluation for submucous palatal defects. The presence or absence of cleft palate dramatically impacts management. Isolated cleft lip allows normal feeding techniques after initial adjustment, while concurrent palatal involvement requires specialized nipples and positioning. Documentation should specify exact anatomic involvement. This precision helps the craniofacial team plan staged repairs and prepares families for the surgical journey ahead. Understanding palatal anatomy clarifies cleft classification. The incisive foramen, located behind the central incisors, divides primary from secondary palate. Primary palate includes the lip, alveolus, and hard palate anterior to this landmark. Secondary palate encompasses the remaining hard palate and entire soft palate. Complete clefts involve both regions, creating communication between oral and nasal cavities along the entire palatal length. Submucous cleft palate challenges diagnosis because intact mucosa masks the underlying defect. The muscle separation prevents normal palatal elevation during feeding and speech. 3 cardinal signs reveal this hidden anomaly. Bifid uvula appears as a split or heart-shaped uvular tip. Zona pellucida shows as a bluish translucent line in the midline soft palate, where muscles failed to unite, and a notched posterior hard palate creates a palpable bony defect. These anatomic distinctions matter immediately in the NICU. Complete clefts prevent any oral suction, requiring specialized bottles that deliver milk with compression rather than negative pressure. Submucous clefts might not manifest until discharge when parents report excessive nasal regurgitation or prolonged feeding times. Early speech therapy consultation for submucous clefts prevents later velopharyngeal insufficiency. Careful oral examination, including palpation of the palate, identifies these subtle defects before feeding problems escalate. Cleft lip and palate affects approximately 1 in 700 births, but this overall number masks important variations. Breaking down the statistic reveals distinct patterns. Isolated cleft lip accounts for 15% of cases, occurring in about 1 in 2,800 births. Combined cleft lip and palate represents the largest group at 45%, affecting 1 in 1,600 babies. Isolated cleft palate comprises the remaining 40% at 1 in 1,700 births. Population genetics significantly influences incidence. Asian and Native American populations show rates nearly double those in Caucasians, while African populations have the lowest incidence. These differences suggest complex genetic contributions beyond simple Mendelian inheritance. Gender patterns also emerge. Cleft lip with or without cleft palate affects males twice as often as females, while isolated cleft palate shows female predominance. The 30% syndromic association demands comprehensive evaluation. Van der Wood syndrome, velocardiofacial syndrome, and Stickler syndrome commonly include clefting. Isolated clefts still warrant genetic consultation, as seemingly non-syndromic cases may represent mild phenotypes or variable expression. Document family history carefully. Even minor lip pits or bifid uvula in relatives suggests genetic contribution. This epidemiologic understanding guides both immediate evaluation and long-term genetic counseling for future pregnancies. Cleft lip and palate creates cascading challenges beyond the obvious anatomic defect. Feeding difficulties top our immediate concerns, particularly with cleft palate. These babies cannot create the negative pressure required for normal sucking. Without proper intervention, they exhaust themselves trying to feed, burning more calories than they consume. Micrognathia accompanying the cleft compounds problems by crowding the airway. Think Pierre Robin's sequence where the tongue falls back, obstructing breathing. Early complications stem primarily from feeding struggles. Poor weight gain follows inevitably when feeds take 45 to 60 minutes yet deliver minimal volume. Aspiration risk increases with palatal clefts as milk freely enters the nasal cavity. Watch for coughing, color changes, or increased respiratory effort during feeds. Bonding concerns arise when mothers cannot breastfeed as planned, and prolonged stressful feeding sessions replace the expected peaceful bonding time. Long-term issues require anticipatory guidance. Speech problems affect nearly all children with cleft palate due to velopharyngeal insufficiency. Air escapes through the nose during speech. Dental anomalies include missing, rotated, or supernumerary teeth at the cleft site. Chronic ear infections result from eustachian tube dysfunction. The palatal muscles normally open these tubes, but cleft anatomy disrupts this mechanism. Understanding these predictable complications helps prepare families for the journey ahead. Feeding success depends on matching technique to anatomy. Babies with isolated cleft lip often breastfeed successfully. The breast tissue molds to fill the cleft, creating adequate seal. Some mothers need positioning adjustments or breast shaping techniques, but many achieve exclusive breastfeeding. This preservation of normal feeding provides tremendous psychological benefit for families processing their baby's diagnosis. Cleft palate eliminates suctionability completely. Standard bottles and breastfeeding become impossible as the open palate prevents negative pressure generation. Specialized feeding systems work through compression rather than suction. The Haberman feeder uses a one-way valve allowing milk flow with gentle squeezing. Pigeon nipples feature similar valve technology with varying flow rates. Dr. Brown's specialty feeders offer another option with controllable flow. Each system requires parent training. Too rapid flow causes choking, while insufficient flow exhausts the baby. Positioning makes the difference between successful feeding and aspiration. Keep babies upright at 45 to 60 degrees, allowing gravity to direct milk toward the esophagus rather than the cleft. Paced feeding prevents overwhelming the baby. Squeeze the bottle during sucking bursts, pause during rest periods. Despite best efforts, some babies require temporary nasogastric supplementation to achieve adequate growth. Frame this as a bridge to oral feeding success, not failure. Most wean from tube feeds once they master their specialized feeding system. Comprehensive cleft care requires coordinated expertise from multiple specialties. Plastic surgery or craniofacial surgery leads surgical planning, timing repairs to optimize both function and appearance. Otolaryngology manages the inevitable ear complications. These children need frequent evaluation and often pressure equalization tubes. Their involvement starts in infancy and continues through adolescence. Speech pathology engagement begins before palate repair. Early intervention teaches parents communication techniques and monitors pre-speech development. Post-repair therapy addresses articulation errors and hypernasality. Genetics evaluation identifies syndromic cases and provides recurrence counseling, crucial given the 3–5% sibling recurrence risk for non-syndromic clefts. Dentistry and orthodontics join the team as teeth emerge, managing the complex dental anomalies at cleft sites. Audiology monitors for conductive hearing loss from chronic effusions. Psychology and social work address the significant psychosocial impact, both parent adjustment to visible difference and later child self-esteem issues. Feeding specialists, often occupational or speech therapists with specialized training, guide families through the immediate challenge of achieving adequate nutrition. This multidisciplinary approach seems overwhelming initially, but families quickly appreciate how each specialist contributes to their child's optimal outcome. Your role includes helping families understand why each team member matters. Surgical planning begins prenatally when ultrasound detects clefting. This early identification allows unhurried counseling, team introductions, and delivery planning at centers with appropriate support. Some centers offer lip adhesion at 2 to 4 weeks, a preliminary procedure that approximates lip segments, potentially improving final repair outcomes. Not all surgeons advocate this approach. Discuss center-specific protocols. Definitive lip repair occurs at 3 to 6 months when facial structures have grown sufficiently for precise reconstruction. The rule of tens, 10 weeks old, 10 pounds, hemoglobin of 10, guides timing, though many centers now operate earlier with good outcomes. Palate repair waits until 9 to 12 months, balancing speech development needs against facial growth concerns. Earlier repair optimizes speech but may restrict maxillary growth. Additional procedures often follow. Velopharyngeal insufficiency, despite good palate repair, may require secondary speech surgery between ages 3 to 5. Alveolar bone grafting at 8 to 10 years, timed with canine tooth eruption, closes the bony cleft and stabilizes the dental arch. Revisions for appearance or function continue through adolescence. Some require orthognathic surgery after growth completion to correct mid-face retrusion. This timeline helps families understand that cleft care extends well beyond infancy, a marathon requiring sustained support rather than a sprint to quick resolution. Micrognathia and retrognathia create similar clinical challenges despite technically different definitions. Micrognathia describes a truly small mandible. The bone itself is underdeveloped. Retrognathia indicates normal-sized mandible positioned too far posteriorly. In practice, distinguishing between them requires lateral skull radiographs and cephalometric measurements, which rarely change immediate management. Most clinicians use the terms interchangeably since both create identical problems. The clinical significance centers on airway compromise. Whether the jaw is small or posteriorly positioned, the tongue base crowds the pharyngeal space. These babies present with stridor, retractions, and oxygen desaturations, particularly when supine. Feeding difficulties follow inevitably. The recessed jaw prevents proper latch for breastfeeding and limits bottle feeding efficiency. Associated anomalies appear frequently enough to warrant comprehensive evaluation. Chromosomal abnormalities, particularly trisomy 18, often include micrognathia as a feature. Growth potential offers hope for many families. Some infants experience significant mandibular catch-up growth during the first year, particularly those with isolated retrognathia. Serial profile photos help document improvement. However, severe micrognathia associated with syndromes typically persists, requiring long-term airway support. Initial severity doesn't always predict outcome. Even babies requiring nasopharyngeal airways initially may achieve normal profiles by school age. This uncertainty makes conservative management with close monitoring the preferred approach when possible. Pierre-Robin sequence demonstrates how one developmental problem cascades into multiple anomalies. The primary defect, mandibular hypoplasia, starts the sequence. The small jaw leaves insufficient room for the tongue, which gets displaced posteriorly. This glossoptosis has two consequences: immediate airway obstruction and interference with palatal fusion during fetal development. The posteriorly positioned tongue prevents the palatal shelves from meeting in the midline, resulting in the characteristic U-shaped cleft. Understanding this as a sequence rather than a syndrome matters for evaluation and counseling. 40% of cases occur in isolation, while the remainder associate with over 40 different syndromes. The mandibular hypoplasia represents the common endpoint of various genetic and environmental insults rather than a single entity. This explains the wide spectrum of severity and associated findings. The U-shaped cleft palate distinguishes Pierre-Robin from typical clefts. Rather than the V-shaped midline cleft seen with isolated palatal clefts, the U configuration reflects where the tongue physically blocked palatal fusion. This wider, more posterior cleft creates greater feeding challenges and often requires modified surgical approaches. Recognition of Pierre-Robin sequence triggers immediate airway assessment and preparation for potential respiratory compromise. Unlike isolated cleft palate, these babies cannot wait for elective evaluation. The glossoptosis threatens the airway from birth. Airway management in Pierre-Robin sequence follows a stepwise progression from simple positioning to surgical intervention. Positioning works for many infants. Prone placement allows gravity to pull the tongue forward, immediately improving airway patency. Side lying offers another option, though watch for positional plagiocephaly with consistent same-side positioning. Supine positioning is absolutely contraindicated. These babies desaturate within minutes on their backs. Parents need safe sleep counseling that acknowledges their baby's unique needs. When positioning fails, nasopharyngeal airways bridge many infants through the critical early months. These soft tubes bypass the tongue obstruction, creating a patent airway from nares to hypopharynx. Parents learn placement and maintenance, including regular replacement to prevent mucus plugging. The airways often allow discharge home while awaiting definitive management or mandibular growth. Surgical options escalate based on severity. Tongue lip adhesion sutures the tongue tip to the lower lip, preventing posterior displacement. Though temporarily disfiguring, it's reversible once the jaw grows. Mandibular distraction osteogenesis gradually lengthens the jaw using hardware, achieving remarkable results in selected cases. Tracheostomy remains the definitive solution for severe cases, but carries long-term care implications. The decision requires balancing immediate safety against developmental considerations. Early tracheostomy guarantees airway security, but may impact speech development and family dynamics. Isolated Pierre-Robin sequence occurs in only 40% of cases, making comprehensive evaluation essential. Stickler syndrome accounts for 20% of Pierre-Robin cases and carries significant implications. This connective tissue disorder causes progressive myopia, potentially leading to retinal detachment, requiring lifelong ophthalmology surveillance. Early identification allows prophylactic treatment preventing blindness. Every Pierre-Robin baby needs ophthalmology evaluation, not just those with confirmed Stickler syndrome. The 22q11 deletion presents with variable features including Pierre-Robin sequence. These children face immunodeficiency, hypocalcemia, and cardiac anomalies alongside their airway concerns. Check calcium levels and T-cell subsets. Treacher-Collins syndrome combines Pierre-Robin features with characteristic facial anomalies, downslanting eyes, malar hypoplasia, and ear malformations. The autosomal dominant inheritance pattern makes genetic counseling crucial. Fetal alcohol syndrome occasionally presents with Pierre-Robin features, though facial characteristics usually suggest the diagnosis. The neurodevelopmental implications extend far beyond airway management. Genetic evaluation helps identify these associations early, guiding both immediate management and long-term surveillance. Even apparently isolated cases warrant genetic consultation. Some syndromes manifest subtly in infancy. Microarray and targeted genetic panels identify causative mutations in about 30% of cases, providing valuable prognostic information and recurrence risks for future pregnancies. Macroglossia describes a tongue that's too large for the oral cavity, creating both functional and anatomic challenges. The distinction between true and relative macroglossia guides management decisions. True macroglossia involves actual tongue enlargement from infiltrative processes or hypertrophy. Relative macroglossia occurs when a normal-sized tongue appears large due to a small oral cavity. Think severe micrognathia where the tongue has nowhere to go. Focal versus generalized patterns help narrow the differential. Focal enlargement suggests masses like lymphangiomas or hemangiomas, often visible as nodular areas. Generalized enlargement points towards systemic conditions affecting the entire tongue. Static macroglossia presents at birth and remains stable, while progressive enlargement signals ongoing infiltrative processes requiring urgent evaluation. The clinical consequences drive our concern. Airway obstruction ranges from mild stertorr to complete upper airway blockage, requiring immediate intervention. Feeding problems arise when the enlarged tongue prevents proper latch or interferes with bolus formation. Persistent drooling results from inability to manage secretions. Later, speech articulation suffers as the tongue cannot achieve precise positioning for consonant production. Document tongue appearance carefully. Smooth versus nodular surface, symmetry, and any color changes guide diagnosis and urgency of intervention. Surface characteristics immediately narrow your differential for macroglossia. Focal masses create irregular, often nodular surfaces. Lymphangiomas appear as clusters of clear or hemorrhagic vesicles, giving the tongue a pebbly appearance. These congenital malformations may suddenly enlarge with viral infections or trauma. Hemangiomas present as compressible vascular masses, often with visible feeding vessels. Both require imaging to determine extent before considering intervention. Generalized smooth enlargement suggests systemic conditions. Beckwith-Wiedemann syndrome causes the most dramatic neonatal macroglossia. These tongues often protrude beyond the lips at rest. Hypothyroidism produces firm, non-pitting enlargement, along with other features like prolonged jaundice and umbilical hernia. Trisomy 21 tongues appear large partly due to hypotonia and mouth breathing, though true hypertrophy also occurs. Storage diseases typically manifest later, but consider them in progressive cases. The distinction matters immediately. Focal masses might require urgent intervention if airway compromise threatens, while systemic causes need different evaluation pathways. Smooth-surfaced generalized macroglossia warrants metabolic screening including thyroid function. Nodular or focal enlargement needs imaging to define anatomy before any intervention. This surface examination takes seconds, but directs your entire evaluation strategy. Beckwith-Wiedemann syndrome represents the classic overgrowth disorder, with macroglossia as its most recognizable feature. 90% of affected infants have obvious tongue enlargement, often dramatic enough to prevent mouth closure. The tongue's constant protrusion leads to drying, cracking, and feeding difficulties from birth. This isn't subtle. These babies cannot contain their tongues within their mouths. The syndrome's features extend well beyond macroglossia. Hemihyperplasia affects one body side, sometimes subtly requiring careful measurement. Omphalocelie, or umbilical hernias, appear frequently. Any baby with omphalocelie needs evaluation for Beckwith-Wiedemann. Characteristic ear findings include posterior helical pits and anterior lobe creases. Neonatal hypoglycemia poses the immediate threat. These babies have hyperinsulinism requiring frequent glucose monitoring and aggressive management during the first 72 hours. Long-term cancer surveillance drives follow-up care. Wilms tumor and hepatoblastoma risks reach 7 to 10%, necessitating regular screening. Current protocols recommend abdominal ultrasounds every 3 months until age 8, with AFP levels every 2 to 3 months during early childhood. Some centers now stratify surveillance based on molecular subtypes, but most continue universal screening given the stakes. Document all features meticulously. Even minor findings like ear pits support the diagnosis and trigger essential tumor surveillance. Management strategies for macroglossia depend on severity, underlying cause, and functional impact. Mild cases often respond to conservative measures. Prone or side positioning uses gravity to prevent airway obstruction during sleep. Oral motor exercises, guided by speech therapy, strengthen tongue control and may prevent worsening dental malocclusion. Many children with mild macroglossia adapt remarkably well without surgical intervention. Surgical tongue reduction becomes necessary when conservative measures fail. Clear indications include persistent airway obstruction despite positioning, severe feeding dysfunction preventing adequate nutrition, or dental malocclusion with open bite deformity. Timing matters. Early surgery for airway concerns, but waiting until age 3 to 4 for speech or dental indications allows better surgical planning. Various techniques exist, from wedge resections to marginal excisions, each with specific advantages. Treating underlying causes takes priority when possible. Congenital hypothyroidism responds dramatically to thyroid replacement. The tongue often normalizes within weeks of starting treatment. Lymphangiomas may respond to sclerotherapy or medical management with sirolimus. Beckwith-Wiedemann tongues often need reduction regardless of other treatments due to their severity. Post-surgical monitoring includes watching for bleeding, assessing feeding tolerance, and ensuring adequate pain control. Most children achieve excellent functional outcomes with appropriate timing of intervention. Cleft palate fundamentally disrupts normal feeding mechanics. These babies cannot generate the negative pressure essential for nutritive sucking, whether breastfeeding or bottle feeding. Success requires specialized equipment that delivers milk through compression rather than suction. Early recognition and appropriate feeding tools prevent the cascade of poor weight gain and family stress. Pierre-Robin sequence demands immediate airway assessment and proactive management. The combination of micrognathia, glossoptosis, and cleft palate creates unpredictable airway dynamics. A baby stable in prone position may obstruct completely when supine. Never underestimate the airway risk. These infants have died during routine care when positioned incorrectly. Establish safe positioning protocols before any other interventions. Macroglossia accompanied by hypoglycemia immediately suggests Beckwith-Wiedemann syndrome. This recognition triggers essential actions: frequent glucose monitoring for the first 72 hours and initiation of long-term tumor surveillance protocols. Missing this diagnosis delays cancer screening with potentially fatal consequences. Craniofacial anomalies require coordinated multidisciplinary care from birth through adolescence. No single specialty can address the complex medical, surgical, developmental, and psychosocial needs. Early team involvement prevents complications, optimizes functional outcomes, and supports families through a challenging journey. Your role includes recognizing these conditions, managing immediate threats, and connecting families with comprehensive team care.